Professor Dr. Jagodish Ghosh, Professor Orthopedic Surgery, Dhaka, Bangladesh. I am now presenting an article review of management of type 2 odontoid fracture in elderly, which have been published in Open Journal of Orthopedics, January 2021. Abstract. Odontoid fracture accounts for 15 to 20% of all cervical spine injuries. Type 2 are the most common type of odontoid fractures. Optimal management of odontoid fracture still has some controversial issue. Non-operative treatment with hollow vest is associated with very high rate of complication in elderly patient. Though surgical treatment has a better outcome, it is limited by age, comorbidity, and hazard of surgery itself. All forms of treatment for the odontoid fracture in elderly is associated with quite high rate of mortality and morbidity. Objectives of this review is to find out the controversial aspect of management along with opinion for a standard guideline for the management. In introduction, odontoid fracture are the most common cervical spine injury of patient older than 70 years. It has a bimodal distribution involving early childhood and the elderly age group. The mechanism responsible for odontoid fracture is generally accepted to be hyperflexion or hyperextension of cervical spine. In contrast to a younger age group, elderly patient had predominantly type 2 fracture. Type 2 odontoid fracture have been associated with limited healing potential, although there is no consensus why type 2 fracture are difficult to heal. Hypotheses include vascular insult, odontoid morphology, and ligamentous forces. Elderly patients with type 2 odontoid fracture are also associated with a high rate of morbidity and mortality regardless of intervention. Because of age-related comorbidities and ubiquitous presence of degenerative changes in the aging cervical spine, elderly patients are at a higher risk of complication and poorer outcome than younger patients sustaining similar injuries. Despite its frequency, there is considerable ambiguity regarding optimal management strategy of this fracture in elderly. In most countries of the world, elderly are the most rapidly growing segment of the society. The treatment of odontoid fracture in elderly requires surgeon's balance, considering patient medical comorbidities, surgical morbidity, and mortality against the high rate of non-union occurring with conservative treatment. Methods and material. A systemic computer-based literature research was performed using PubMed, Google Scholar-based database, using the headings like odontoid fracture, type 2 operative management, and non-operative. Now results. Overview of odontoid fracture. Several anatomical and morphological studies have described the trabecular anatomy of the odontoid process. These traditionally divide odontoid process into three structural distinct regions: the tip, body, and the base, as shown in the figure on the right side. As patient age increases, there is relatively larger reduction in bone density at the odontoid base relative to the remainder of the axis. The structural weakness of the odontoid base, coupled with increased bone loss due to age, may underlie the high rate of odontoid fracture in geriatric patients. Treatment options. Though there may be conservative treatment and surgical treatment can also be provided to the patient, we are first discussing about the conservative means of treatment using the hollow vest. Hollow vest, though developed for the management of patient with poliomyelitis, it had been gradually adopted in the management of treatment of odontoid fracture. But its complication rate, that is the morbidity and mortality, is higher, even up to 51% and 41% respectively. So it should be cautious during use of hollow vest orthosis in case of management of fracture odontoid in elderly especially. Cervical collar immobilization. Soft collar are not stabilizing. Hard collar, such as Philadelphia, may be used in the first phase of the unstable fracture until a decision for further option, or may be used as a definitive treatment for 6 to 2 weeks in case of non-operative treatment is selected. Using this strategy of cervical collar immobilization, the success rate for management of odontoid type 2 fracture ranges below 75%. While cervical collar are generally well tolerated without a risk of serious adverse effect, the increased motion may theoretically increase the risk of non-union. Surgical treatment. Surgical stabilization of odontoid fracture may be done either by anterior screw fixation or a posterior cervical 1, cervical 2 fusion. Anterior odontoid fixation has the advantage of preserving atlantoaxial motion and minimally invasive in terms of exposure and muscle damage. In elderly patients, surgical treatment of type 2 odontoid fracture is justified by the excellent fusion rate, which allows the patient to quickly regain their pre-injury autonomy. Currently, anterior screw fixation has been a popular surgical treatment option. The reported success rate have been relatively high, averaging 94.5%. Now we are going for discussion of this review. Every elderly patient with odontoid fracture are a high-risk group with high morbidity and mortality. Treatment option of odontoid fracture varies from conservative management with external immobilization with cervical collar or other cervical orthosis to operative management with anterior odontoid fixation or posterior cervical fusion with or without supplemental screw application. It's evident from study that each option of treatment has a role and the management has to be individualized. And considering the optimal treatment of type 2 odontoid fracture in the elderly, several factors need to be taken into consideration, including medical comorbidities, healing potential of the fracture, anticipated tolerance of hollow vest or surgery, and patient wishes. The concept of ideal treatment for type 2 odontoid fracture in elderly is that treatment which would provide the best functional outcome with the least associated risk and not simply the best surgical outcome alone. Conservative treatment has the advantage to avoid anesthesia and surgical risk, but associated with relatively elevated risk of non-union. Age and comorbidities influence mortality and complication rate the most, regardless of fracture type and treatment choice. Stable to odontoid fracture, that is stable type 2 odontoid fracture, can be successfully treated with non-rigid immobilization, even if they are displaced. But unstable injuries of the odontoid are hazardous to every elderly person since they are associated with dysphagia and respiratory restriction, and these are the potentially deadly complications. It is important to adopt an aggressive diagnostic approach to detect unstable fracture. With advancing age, there is relatively larger reduction in bone density at the base of the odontoid related to the remainder of the axis. Odontoid non-union and instability are high in geriatric patients treated with a rigid cervical collar. Use of hollow vest is also associated with high rate of complication. Surgical treatment provides a high rate of union but is limited by the age-related comorbidities, and mortality risk increases with advancing age and number of comorbidities. With such limitation, The report or data suggests that surgery may offer a protective benefit in patients less than 70 years of age. We have some limitation of this study. The limitations are separate analysis of data regarding type 2 fracture and elderly patient was not possible. Chance of adoption of advanced search technique was limited. In conclusion, there is no evidence-based treatment protocol or standard guideline for management of odontoid fracture in elderly has yet been developed. The incidence of odontoid fracture are likely to be increased in future throughout the world as longevity of people are increasing. All modalities of management are associated with quite high rate of morbidity and mortality. In planning treatment of odontoid type 2 fracture in elderly,